PCOS, Polycystic Ovarian Syndrome. Today I'm going to go through the pathophysiology and cause and treatment of this distressing condition, which has become extremely common together with many other modern chronic conditions like obesity, diabetes, metabolic syndrome, hypertension, Alzheimer's, anxiety, because they are fundamentally all caused by the same thing: high insulin and insulin resistance. Before we can understand the pathology behind PCOS, we need to first go over how the normal female menstrual cycle works. Let's look at an average 28-day cycle beginning on day 1, which is the first day of bleeding. This is a low progesterone, low estrogen state where the hypothalamus is not inhibited, so it is actively pulsing, inducing the pituitary to produce 2 hormones. Follicle stimulating hormone causes the primordial follicle in the ovary to start maturing. Actually, 10 to 15 of these start maturing, but only the strongest one survives. It also helps the follicle to secrete estrogen. This is called the follicular phase of the menstrual cycle. Luteinizing hormone is also needed for estrogen secretion from the follicles, and a spurt of luteinizing hormone is induced by a critical estrogen level just before ovulation and causes the ovulation to occur. Ovulation is when the ovum leaves the follicle and goes into the fallopian tube to be fertilized. This is known as the luteal phase, which is after ovulation. If we look at this hormone profile here, the cycle starts with bleeding. FSH and LH are maturing the follicle and they are rising. Just before ovulation, at a critical estrogen level, there is a spurt of LH, which induces ovulation. The corpus luteum starts producing a lot of progesterone and some estrogen. This feeds back to the hypothalamus to inhibit FSH and LH. When the FSH and LH is inhibited, the corpus luteum cannot be sustained and it dies and stops producing progesterone and estrogen. Meanwhile, let's have a look at what's happening in the endometrium of the uterus. In the menstrual phase, we have a low progesterone estrogen state, so the endometrium sloughs and we get 5 to 7 days of bleeding. In the proliferative phase, estrogen is rising, so the endometrium thickens and becomes more vascular. The mucus becomes thin and sperm friendly until we ovulate and we reach the secretory phase. In this phase, the corpus luteum starts producing a lot of progesterone and the endometrium thickens even further. The mucus becomes thick and the cervix closes so that nothing can come in and out of the cervix, other sperm or bacteria and so on. The idea is that it's meant to retain the fetus. If, on the other hand, if fertilization takes place, then the fetus produces human chorionic gonadotropin, HCG, and this sustains the corpus luteum so that it is able to continue producing progesterone and estrogen until about 5 weeks, when the placenta will take over and produce these hormones. Progesterone and estrogen then remains high for the duration of the pregnancy. Okay, that's a lot to take in, so let's recap the menstrual cycle. The hypothalamus in the low estrogen progesterone state produces a lot of GnRH, which stimulates the anterior pituitary to produce LH and FSH. FSH matures the follicle and stimulates the follicular cells. LH induces ovulation and stimulates the thecal cells, and they both together cause the follicle to secrete estrogen. They also both sustain the corpus luteum, which produces estrogen and progesterone. So the follicle produces estrogen, which sustains the endometrium and starts preparing it for a pregnancy. It also feeds back to the hypothalamus to start cutting off FSH and LH. The corpus luteum produces a lot of progesterone and some estrogen. It sustains the placenta and further matures it, and it also feeds back to the hypothalamus to cut off FSH and LH, which results in low estrogen and low progesterone and menstruation, unless there's fertilization. Let's have a look at the pathophysiology of PCOS. This is a follicle. These are the thecal cells. These are the follicular cells. And this is the oocyte. So what happens is that the thecal cells, under the influence of LH, produce androstenedione, which is an androgen precursor. The follicular cells, under FSH, produce aromatase. And what aromatase does is it diverts the androstenedione to 17-beta estradiol and other estrogens. The problem in PCOS is that there is a relative shortage of FSH. And if you measure LH and FSH in a PCOS patient, the ratio is 3 LHs to 1 FSH. So what then happens is that you don't have enough aromatase, and more of this androstenedione becomes androgens. And this explains the androgenization that occurs in PCOS. In PCOS, there's a shortage of FSH. So the primordial follicle over here only develops to about 8 millimeters. A normal ovulatory follicle is 10 to 15 millimeters. So there is no ovulation, and these unovulated follicles become the cysts that you see in PCOS. So what you see here is a normal ovary and a polycystic ovary. This is an ultrasound showing a normal ovary, and here you can see all the cysts in the polycystic ovary. And also, because there's unopposed estrogen acting on the endometrium, you get endometrial hyperplasia and you get menstrual irregularities, either no menstruation at all or oligomenstruation. So let's have a look at the etiology. When there's high insulin interferes with GnRH. There's a selective decrease in FSH from the pituitary. And we don't know exactly how it does this, but it uses the well-known P450 enzyme system. And insulin also acts directly on aromatase to inhibit it. In the liver inhibits androgen-binding globulin production. So this results in more free testosterone, hence the androgenization. And androgens themselves promote insulin resistance. So as the insulin resistance increases, there is hyperinsulinemia, and this becomes a vicious cycle. Let's have a look at the clinical picture of PCOS. And the Rotterdam criteria require that we have 2 of the following 3 things. The first one is you need to have menstrual irregularities with oligo or amenorrhea and poor ovulation. There's hyperandrogenism. This can be clinical and or laboratory findings. The clinical ones are hirsutism, acne vulgaris, male pattern baldness, acanthus nigricans. And we can measure the free testosterone, which will be high, the estrogen and progesterone will be low, and the LH-FSH ratio will be greater than 3. The third thing is that you must have polycystic ovaries, and this is diagnosed on transvaginal ultrasound. So you need 2 of these 3 to diagnose PCOS. Let's have a look at the associated conditions. And this will come as no surprise because increased insulin causes PCOS. So all of these illnesses are hyperinsulinemia, insulin-resistant diseases. Obesity and overweight, metabolic syndrome, insulin resistance, diabetes and gestational diabetes, all of these are more common in PCOS. Infertility is because of anovulation. Obstructive sleep apnea is an insulin disease due to overweight. Non-alcoholic fatty liver disease, cardiovascular disease, endometrial cancer is due to unopposed estrogen with endometrial hypertrophy, depression and anxiety. All of these are related to the increased insulin state. And we know this, it's in our journals, hyperinsulinemia causing all of these things. But strangely enough, when it comes to treatment, this logic seems to break down. So this is what we teach our medical students and hence our gynecologists. Diet and exercise is mentioned in the beginning, and it means a low-calorie diet and exercise. And as we know, 99% of low-calorie diets fail. So the medical students almost say, yeah, diet and exercise. Let's move on. What's the real treatment? So the one thing we do is if the lady does not want to become pregnant, we give a combined oral contraceptive. At least she's getting some progesterone and she's able to have periods, and it possibly reduces the incidence of endometrial cancer. We treat the hyperandrogenism with finasteride, which blocks testosterone conversion to the active form of testosterone. Spironolactone blocks androgens at the periphery. Eflornithine cream is a hair removal cream. And the newest treatments are gonadotropin releasing hormone agonists, which there is some research into. Metformin we use to increase the insulin sensitivity, and at least this has some logical reason for why we do it. But no drug can treat insulin resistance and lower insulin without the proper diet and fasting. Then we give clomiphene or letrozole. What this does, it induces ovulation by blocking the estrogen feedback to the hypothalamus, and therefore the hypothalamus is induced to produce more LH and FSH. And then the craziest one of all is ovarian wedge resection. The only reason I can see that this may help is if you are removing some of the follicles that are producing androgens. So we treat all the symptoms on the periphery, and we don't treat the root cause, which is high insulin. So the effective way of treating PCOS is to treat the cause, which is high insulin. And how do we do that? We do that with ketogenic diets, with low carbohydrate diets, and with intermittent fasting, which is also known as time-restricted eating. If you want to know more about that, you can go to my channel, which is this URL over here. I'll leave it in the at the bottom of this video. And if you don't think this works, ask Dr. Jason Fung. He is the Ronaldo of insulin resistance and diabetes reversal. And the gynecologists in the IVF clinic started referring their patients to him, and lo and behold, when they went on his protocol, they fell pregnant. Many of them after failed IVFs. So thank you for listening, and I'll see you in the next one.